Good evening, everyone. First of all, on behalf of Intas Pharmaceuticals and the Nexa division of Intas, I, Dr. Sandesh Vodkar, very warmly welcome you to yet another episode of Lipitas Lectures. As there is increasing burden of dyslipidemia, and we all know that the impact of dyslipidemia on cardiometabolic health. So that is why it becomes imperative for us to discuss the burning topics in the management of these conditions. So our today's topic is inflammation, the hidden risk in heart disease. And without much ado, now I would take this opportunity to introduce and welcome our chairperson for our today's talk, Dr. KP Suresh Kumar, sir. Dr. Suresh Kumar has more than 30 years of experience in clinical and interventional cardiology. He completed MBBS and MD at Calicut Medical College and DM at CMC Vellore, earning top honors. He is FSCC, FSCAI, FESC, and FRCP from UK, and he is a recipient of numerous awards like Best Doctor, IMA 2018, Healthcare Achievers 2020, and Kaveri Ratna 2025. He is a respected teacher, mentor, and speaker at various national and scientific summits with more than 23 publications on his name. His expertise includes coronary heart disease, interventions, heart failure, and hypertension. So with this, I welcome Dr. Suresh Kumar, and I would request Dr. Suresh Kumar to introduce the speaker for our today's session, Dr. Ramakrishnan. So over to you, sir.
Thank you, Dr. Sandesh, for your kind introduction. Next couple of minutes, I will do a context setting before I introduce Dr. Ramakrishnan and hand over the podium to him. We all know that LDL is the primary target of therapy in patients with dyslipidemia, and reduction of LDL is fundamental in treating atherosclerosis and preventing adverse events. We have got battery of secondary prevention trials and primary prevention trials, which have shown that earlier is better, lower the better, longer the better, and together the better. So even if you keep the LDL in single digits, it is beneficial, which has been shown in Fourier trial that if you compare people with LDL of 40 to LDL of 20, people of LDL 20 has done better, less adverse events. We have got statins, bempedoic acid, ezetimibe, and the PCSK9 inhibitors and inclisiran for this. Still, with all these molecules available, still there is a lot of residual risk to the patient for the development of atherosclerosis and progressional disease and clinical events. All this residual risk comes mainly from inflammation. So vascular inflammation is a reality, which we know. We have been talking about quite a long time about this. Now, so inflammation is now a target of therapy to prevent the progression of atherosclerosis and to prevent the adverse events. So let us listen to Professor Ramakrishnan, who is a professor of cardiology at All India Medical Institute, New Delhi. He has completed his MBBS from Madurai Medical College and MD General Medicine from King George Medical College. He has more than 325 publications. He is a recipient of several awards, D.P. Basu, Nanda, Sujoy B. Roy, and Kerala Chopra, and multiple Young Investigator and Best Paper Awards. He is recognized as one of the top 2% scientists across the world as per the standard at Stanford University's list of 2025. He is a proficient in echocardiography and interventional cardiology, and a pioneer in the alcohol ablation of septum in HOCM. He has played key role in Mission Delhi, STEMI, ACT, IHMI, and rheumatic study. And he has organized major cardiology conferences and workshops. He's a fellow of American College of Cardiology and SKY and PFICS. Over to you, Professor Ramakrishnan.
Thank you, sir. Thank you for such a kind introduction. So I will be just sharing the slides. So this is, I think, the kind of the heart of the matter, where we all know that I think inflammation plays a key role in atherosclerosis right now. There is no doubt about that. The major focus in India should be in getting the patients on adequate doses of appropriate doses of the primary treatment that is recommended. That is primarily mostly statins, ezetimibe and bempedoic acid. So the problem why I'm saying is that most of the patients who need secondary prevention, only roughly around 15 to 20% are actually treated to goal in India. So the overall number of patients who are on statin in this country is a minuscule of likely beneficial patients of statin. So that is the primary thing that I think India as a country should be focusing on, providing primary prevention as well as secondary prevention to those patients who are indicated of statin. But we know that in spite of statin also, statin could take care of, say, 30% of all the risk that happens. The most of the things, even despite all the therapy that give, there is a tremendous amount of residual risk. What you are going to do with the residual risk? So the residual risk can be dealt with in lipid hypothesis area or in non-lipid hypothesis areas. So what is causing this residual risk? So in an ideal scenario, the moment you don't have a residual risk, that means you are going to become immortal. You are not going to die of cardiovascular disease. That is never going to happen. So we are all going to die of, say, cardiovascular disease. Most of us are going to die of cardiovascular disease. But the important point is we want to prevent premature atherosclerosis and premature CVD and premature deaths, where possibly inflammation plays a very, very critical role. So traditionally, we have been focusing on LDL cholesterol and atherogenic lipoprotein all the time. So inflammation is known to play all stages of atherosclerosis. And statins, possibly we all understood that statins pleiotropic effects are because of anti-inflammatory actions far beyond LDL-C reduction. And now there are landmark trials like CANTOS with canakinumab, and the Jupiter trials highlight the inflammation as an independent risk pathway. The residual inflammatory risk, that is we are going to talk about today, persists despite optimal LDL-C control. So the aim is to integrate inflammatory markers into CV risk stratification and management. So atherosclerosis is now understood to be a chronic inflammatory disease. The endothelial dysfunction triggers monocyte adhesion and cytokine release, and the foam cell formation activates innate immunity and inflammasomes. So IL-1 beta, IL-6, CRP actually amplify the local and systemic inflammation. And the most importantly, now we understand that the plaque rupture is usually facilitated by matrix metalloproteinases and the inflammatory cells. And the thrombus formation is driven by procoagulant effect of the inflammatory mediators. The whole cascade from the initiation of atherosclerosis to the initiation of the plaque rupture and acute MI is all mediated by inflammation. As humankind, we have a very good understanding of acute inflammation, like how acute inflammation happens. But this kind of a chronic indolent inflammation, we have very little idea, and a lot of is being explored. So some of the pathways that are involved are the low-grade inflammation that happens leads to metabolic dysfunction as well as systematic inflammatory response, and then the focus could also lead to inflammation. So basically, a lot of these factors pooled in, and they produce acute as well as systemic chronic inflammation, including aging, generalized hypoxia, generalized triggers like hypoxia, or even microbial toxins like antigens and all those things. For example, we are looking at the proposal of why do Indians get heart attack early. One of the hypotheses we are looking at is whether we all are suffering because of a latent tuberculosis hitting the inflammatory pathways and the inflammasomes that are getting activated because of latent tuberculosis. So a lot of people are working on a lot of areas, inflammation, infection. So all those things are being interrelated. What is triggering this inflammation? What is actually the cause of inflammation that produces that plaque rupture is an area of active inflammation. The moment a breakthrough happens, I think we will have a bigger molecule coming in. So despite the shortcomings of not understanding it a lot well, but a lot of things have been obtained. So the most important thing is oxidation of LDL and the formation of foam cells. These are central that have been understood for ages now, and a lot of them are being because of pro-inflammatory cytokines that are released not only in the system but also locally. So, for example, anything like endothelial injury, hemodynamic damage, and lipid accumulation, all of them they attract the monocyte chemoattractants that are upregulated, and they activate the inflammatory mediators, ultimately resulting in atherosclerotic plaque, vulnerable plaque being formed and leading on to plaque rupture. So we need to understand as physicians, many patients who achieve the LDL goal, we all would have seen many patients who are absolutely managing themselves in terms of lifestyle modification, who are all their risk factors are controlled, LDL-C is under goal, but still they have significant risk of cardiovascular events. So this is what we call it as one of the risks could be the residual inflammatory risk. So the residual inflammatory risk is particularly high in patients with diabetes, in patients with CKD, obesity, and smokers. So one of the things is elevated HSCRP. We all have understood that is an important signal of ongoing vascular inflammation, especially when, despite statin, when on adequate dose of statin, anti-inflammatory, the inflammatory markers are elevated. That means we are in trouble. So anti-inflammatory interventions offer an untapped therapeutic frontier, which have been now explored with the advent of various molecules that we'll be discussing later. So in nutshell, with the residual inflammatory risk, we should move from a lipid-centric into a multi-axis risk management. So what are the key inflammatory biomarkers in cardiovascular disease? The key inflammatory biomarkers include HSCRP, the interleukin-6, the interleukin-1 beta, the LPPLA2, and the myeloperoxidase, and fibrinogen. And there are very many. Like, if you're interested, there are good articles in Circulation Research that looked at all the markers that are possible. That is actually a 30-page article into two parts. So the HSCRP and its clinical utility is the most widely used and the most widely recognized. So one of the important things is elevated HSCRP is known to predict stroke, cardiovascular death, even in patients with controlled LDL cholesterol. There is a strong correlation between HSCRP and IL-6 levels, and the Jupiter and Cantas actually used HSCRP to risk stratify the high inflammatory risk patients who are likely to respond to these therapies, the canakinumab in Cantas as well as the rosuvastatin in Jupiter trials. So HSCRP levels are modifiable with statins, lifestyle changes, and anti-IL-1 therapies. The limitation is it's actually elevated in any infection, trauma, and chronic illnesses. So this is a very important slide for us to understand. In patients with stable coronary artery disease, whose LDL is not in target, almost 42% of them have a high LDL, high HSCRP. The moment the LDL is reduced to 70, even then 30% are likely to have very high HSCRP. So that's a very important thing. Even though the markers that the LDL is under control, but then still HSCRP is very high. So 1/3 of all comers with CHD show increased level of HSCRP despite LDL cholesterol being less than 50. So statins in high doses and ezetimibe have been known to reduce HSCRP, whereas elevated pro-BNP is known to increase HSCRP. So interleukin-6 is emerging as an important central mediator of inflammation in all these things. The IL-6 actually acts through CRP production in the liver, and it correlates with vascular inflammation. The genetic variation of the IL-6 receptor is linked to various CHD risk in Mendelian randomization studies, and they independently predict the cardiovascular events. So IL-6 blockade may offer upstream suppression, and there are the very good early results have been obtained with specific monoclonal antibodies targeting IL-6 receptors. So possibly IL-6 modulation may be an important target to target CRP. So what are the predictors of HSCRP? So the clearly of all the parameters that were tested, all these IL-6, serum amyloid protein, and all the various other markers that were tested, the highest was IL-6. So the high-risk characteristics were age, obesity, diabetes, patients with heart failure, patients with renal damage, patients with extensive CAD, and patients with continued smoking all had excessive risk of outcomes, bad outcomes, and IL-6 was the best predictor of all the bad outcomes that are associated from the Lurik study. One of the landmark studies that actually established the role of HSCRP was the Jupiter trial. So it investigated rosuvastatin in 20 mg in patients with LDL cholesterol less than 130 with a HSCRP of greater than 2 mg. Compared to a placebo, there was 44% reduction in MACE events compared to placebo. The trial was so effective that it was actually prematurely terminated. So demonstrated that inflammation alone is a valid therapeutic target. HSCRP reduction paralleled LDL-C lowering in predicting outcome. The subgroup analysis showed benefit across age, sex, metabolic risk groups. And actually, it established the dual goal of LDL-C lowering and inflammation suppression. So this is a very important slide that actually shows the effect of rosuvastatin when it's stratified to how the patients responded to the LDL cholesterol and the percentage reduction in LDL cholesterol, or HSCRP reduction to less than 2 mg and HSCRP reduction by 50%. The graphs are parallel. So what in effect is the effect of rosuvastatin is far more in people who achieved greater than 50% reduction in cholesterol, LDL-C that was less than 70, and HSCRP less than 2, and HSCRP reduction greater than 50. So they were actually parallel. So CANTAS is another very important landmark trial that used canakinumab, which is IL-1 beta blockade, in post-MA patient with high HSCRP. It demonstrated 15% reduction in MACE independent of the lipid changes. Even though the trial did not lead to approval of canakinumab because of the higher cost and the infection risk, but the NNT was comparable to statin. But more importantly, it confirmed the causality of inflammation in atherothrombosis. So HSCRP responders had greatest benefit, suggesting the need for a biomarker-guided therapy. It actually paved the way for an immune-targeted approach in CV diseases. Even though 5 years down the line, canakinumab is out, we are no longer going to use it because of active inflammations are far more, and including activation of tuberculosis was far more. So this is one of the hypotheses why we are looking at latent tuberculosis, whether actually could be because canakinumab is inducing active tuberculosis. So one of the reasons could be that active tuberculosis or latent tuberculosis may be one of the reasons why Indians are at a higher risk of this thing. The cumulative incidence of cardiovascular events in the placebo group and the combined 3 months clearly demonstrated that the HSCRP was an independent risk marker that could differentiate who are likely to respond to canakinumab. The other important group of evidence for inflammation in atherothrombosis, atherosclerosis comes from the group of trials of colchicine. So colchicine, we don't know. We have been using this molecule for ages now, but we don't know the exact mechanism of action. It has a lot of anti-inflammatory activity through inflammasomes and neutrophils. The LODOCO-2 trial as well the COLCAT trial showed MACE reduction, even though the latest trial did not show. But it is a cost-effective, orally available anti-inflammatory effect. But most importantly, the GA tolerance is a very, very potential limiting factor. So now we have 3 targets that are acting. Canakinumab, we know rosuvastatin or statins act through anti-inflammatory pathway, but they have a very broader. We don't exactly know the pathway. But canakinumab is a specific agent that acts specifically, and then colchicine, we understand some of it, how it acts. So we understand more or less how the atherothrombosis and the endothelial injury stimulates inflammation and activation that happens through that. So what are the clinical implications of all this I told you? Like initially I told you what is the residual inflammatory risk. Then we discussed about the importance of residual inflammatory risk, how it is likely to pay. And the other important thing is what are the clinical evidences through various molecules that are emerging, that what are the likely targets for inflammation. Now, what are the clinical implications? Why should a clinician be worried about inflammation? So we all understand that patients who achieve the LDL target, diabetes is under control, hypertension is under control, still are at a risk of atherothrombosis and inflammation. The residual inflammatory risk predicts future MACE independently of lipids. So clearly, Jupiter and CANTAS have demonstrated that HSCRP reduction reduces events. The statin non-responders remain at a higher risk of residual risk, even if the LDL cholesterol is less than 70. So recognizing residual inflammatory risk facilitates risk reclassification in patients with stable CAD, and inflammation-targeted therapy may be most valuable in residual risk subset. But there's a big discordance between the LDL-C and inflammation. So initially, before treatment, there is a reasonable concordance, at least in 50% of the patient, that between LDL and inflammation. But the moment you treat inflammation, mainly the statins are able to take care of part of it, but still 30% of patients remain, their lipids are under control. They don't have much of a residual lipid risk. but they are at a very high risk of residual inflammatory risk. That leads to the inflammation lipid dual risk model. One of the key thing that is emerging is this NLRP3 inflammasome. It's actually both the colchicine and canakinumab exert anti-inflammatory pathways via this pathway. So there are various reasons why we should be looking at and how this pathway produce. It looks like a very good target mode for this. How do you understand inflammation? Apart from your HSCRP, can you have other modalities to diagnose inflammation? So FDG PET is very accurate to find out arterial wall metabolic activity. Like you must have seen in arthritis, we keep on doing FDG. Similar amount of inflammation, not at that quantity, but some amount of inflammation is there. But inflammatory infiltrates into atherosclerotic plaques in experimental T2 weighted MRI has been shown to identify inflamed plaques. The NIRS is a very good method to identify lipid-rich inflamed plaques. The hybrid imaging combining both PET and MRI actually could be the future. And the imaging complements the biomarkers for localizing inflammation. So inflammation to diagnose, the imaging to diagnose inflammation could be the future where we'll be doing it like. Not only CAD, we all understand cardiovascular disease is a spectrum. So inflammation is a very, very important predictor of heart failure. So these are the various reasons why it could be a very important factor. So there are two major trials. Fortunately, one of the large trials that I think we got funding from ICMR this time is going to be a large trial led by Dr. Nagendra Bhupati from SRMC, nearly 3,000 patient trial, one of its kind in India, where we are going to randomize patients with HREF into colchicine versus placebo, matched placebo. And that could be a game changer if it comes positive. And the same Salim Yusuf group is also doing another trial of colchicine in a broader spectrum of ischemic heart failure patients. So our trial is mostly into both ischemic as well as dilated cardiomyopathy subgroup. Whereas the multicentric, multinational trial initiated by Salim Yusuf will be on specific ischemic subset. So this could be another path-breaking area where if both the trials come positive, colchicine become another new pathway for managing heart failure. So, and importantly, inflammation is very, very well understood to be part of atrial fibrillation. There are post-operative, clearly there is systemic inflammation. There are a lot of systemic inflammatory diseases in which AF is well known to happen. And it's actually becoming more and more well-established inflammation and atrial fibrillation. Same thing goes on with the pulmonary, but the peripheral arterial disease, where the CANTAS clearly showed that the canakinumab resulted in reduced MACE in PAD, and these are the various evidences that exist in peripheral arterial disease also. So statins, how do the anti-inflammatory effects happen? So clearly we know statins have pleiotropic effect. Some of these pleiotropic effects are being understood with the advent of the understanding of inflammasomes. The NFK beta signaling is well known to be affected by statins. That may be the primary reason how they reduce CRP. And there are multiple pathways they reduce. And the greatest reduction is seen with the high intensity statin, that is mostly the proven being rosuvastatin. And the CRP reduction is consistently shown to be independent of LDL-C reduction. So the statins not only reduce the systemic inflammation, but also reduce the plaque level inflammation shown by MRI imaging and NIRS imaging. So that may be the reason why they are more effective than what they produce with just LDL-C reduction. So not only statin, some of the newer agents that have plenty of cardiovascular protection, like the GLP-1 agonist, the SGLT2 inhibitors, all shown to have the AC inhibitors and aspirin, all of them shown to have significant effect of inflammation through various pathways. Even bempedoic acid is shown to have some effects like. And more and more dysbiosis and the gut microbiota are known to be involved in inflammation through various pathways, and then maybe the microbiome profile may be the responsible for why somebody develops an MI on that particular day. And one of the common thread in the whole thing is obesity and diabetes. These are emerging as a very, very key important risk factors for high inflammation in patients who have LDLC, which is under control. So chronic low-grade inflammation is known to underlie endothelial dysfunction as well as insulin resistance in diabetes. Diabetes have elevated IL-6 and CRP and TNF-alpha, and inflammation accelerates atherosclerosis and plaque instability in type 2 diabetes. So CVOT trials of SGLT2 and GLP-1 agonists have clearly show both reduction in glycemia as well as inflammation. Again, these group of drugs are clearly known to be associated with especially SGLT2 inhibitors, not so great reduction in glycemic indexes, but very good reduction in CVOT outcomes, possibly because of their profound effects on inflammatory pathways. So again, dialysis is another emerging thing where I think inflammation plays a very critical role. And then how do you profile a patient? Like suppose you get a patient, how do you think of inflammation? The simplest step that we can do is hsCRP and lipoprotein little, which actually can help you in enhanced risk discrimination. They can be added to a polygenic risk score, and then possibly some of the trials that clearly showed the inflammation profiling could guide therapy actually. The inflammatory signature may help stratify patients post-ACS and revascularization. So integration of imaging data could also become the future of precision cardiovascular medicine. So biomarker-guided therapy may become the new paradigm. So clearly we understood a lot through COVID-19, how COVID-19 increased the risk of MI, mostly driven by inflammation. So colchicine, steroid, and IL-6 inhibitors were used in severe cases. So the anti-inflammatory therapies, the problem with anti-inflammatory therapies, all of them were the safety concerns. Except for statin, none of them are so well tolerated. Especially colchicine had neutropenia and elevated liver enzymes, and mainly gastrointestinal side effects were the major problems, especially rarely myopathy was a problem. The IL-1 and IL-6 blockers increase risk of inflammation due to a diffuse suppression of immunity. So the careful selection and monitoring are essential. So how do you go about it? Like how do you integrate biomarkers into guidelines? So most of the guidelines still recommend LDLC goals, but the ESC recognizes inflammation, the residual risk, but lacks a formal algorithm. But IACC and AHA highlights hsCRP in intermediate risk assessment, but it is not routinely implemented. But with more and more evidence, with targeted therapy coming, the guidelines may update incorporating inflammatory risk scoring as the future. So hsCRP is a very, very important risk marker. We know. When do you do? So you do risk stratification when there is an intermediate class. For example, it's not so very effective in a primary prevention situation when you definitely is a high risk. The patient has to be on good amount of statin. There is no point in getting hsCRP done. But in an intermediate zone where you are worried about whether you want to start statin or not, then possibly this is a very good test to reclassify the patients into whether they need a statin or not. So secondary prevention, it actually could aid in patients who are getting recurrent events despite a good risk factor control. It can identify residual inflammatory risk after LDL cholesterol is controlled. But the moment you get a hsCRP or CRP, if it is more than 10, just ignore the result. That is because mostly it will be because of an inflammatory condition. That means recent infection or a basic inflammatory condition like SLE or rheumatoid arthritis or something else. You just rule out all of them and then repeat the test. And then if it is generally abnormal, it is more than 2. The beyond 10, it should not be interpreted like that. So it should be checked 2 times, at least 2 weeks apart. So it can be checked in all these conditions also. So this is where the guidelines recommendation, what I told you, is it's mostly important in 5 to 7.5 risk, that is intermediate risk, where it is useful. There are a lot of emerging trials that are there. IL-6 Jesus and Rescue trial, the Lodoco MI is already released. Precision inflammation is multi-omic and AI to predict residual inflammatory risk. And there are a lot of dual pathway inhibition. And we are also doing a very large trial of around 3,000 patients to understand the risk link between why do Indians get a early heart attack, looking at various inflammation and the lipid pathway that are there. And the mRNA-based therapies are coming up. So there are a lot of challenges that are in clinical practice. I think we all understand the challenges because there is no effective therapy. That is beyond statin, there is no effective therapy. That is where the challenges. But in future, it has a huge role. I think future will be the drugs to control inflammation will be the future. So primarily, all the risk factors: stop smoking, blood pressure control, blood sugar control, lipid under control, and inflammation under control will become the future. So the personalized treatment guided by inflammatory phenotype and response could be the future, and maybe EA integrated biomarker model in the emergency could become the future. And then we'll have a one go multi-marker panel that could identify like nowadays we do TROP, BNP, and everything in the emergency. Maybe some other tests become the standard. So this may be the one. So to summarize, inflammation is a key residual risk in ASCVD, which is definitely independent of LDLC. HSCRP and IL-6 are powerful biomarkers in the risk prediction and treatment targeting. The landmark trials clearly documented the use of canacubimab, rosuvastatin, as well as colchicine. There is definitely benefit of the inflammatory pathway in reducing clinical events. But none of them are so much well established, except for maybe colchicine currently, which is approved in some of the indication. But again, 2 trials are positive. One big trial was negative. We don't know how to place because the indications were slightly different in all these trials. The anti-inflammatory therapy represents the next frontier in cardiometabolic care. Clinicians should adopt a dual lens in lipid control and inflammation reduction. Inflammatory, right now, HSCRP must be tested in patients who are definitely presenting with a second event despite a good risk factor control, or in patients for primary prevention who are in the intermediate risk category. So time to go beyond LDLC to identify, track, and treat inflammation in the heart. So thank you for patient listening.
Thank you. Thank you, Professor Ramakrishnan, for your insightful presentation on the role of inflammation in the pathogenesis of atherosclerosis and inflammation as the key target for the treatment of atherosclerosis to prevent atherosclerotic cardiovascular events. Now, to sum up, see, all patients with established atherosclerotic cardiovascular disease has ongoing low-grade inflammation. Apart from that, which are the patients in which you clinically suspect inflammation? All diabetics, smokers, obese people, people with visceral adiposity, people with CKD, lack of physical exercise, metabolic syndrome, and CKM syndrome. All these people, there's a higher, people with non-alcoholic steatohepatitis. All these people will have definitely a higher amount of vascular inflammation. Now, we all know that all patients, in general or public, LDL should be less than 100. All diabetic, it should be less than 70. People who had a cardiac event, it should be less than 50. People who are recurrent cardiac events, keep it less than 30. Because LDL is the target of therapy. But you have to think beyond LDL. That's what all the talk is all about. You have to take care of the inflammation. High intensity statins really take care of the inflammations. But can you do something more than that? You can check C-reactive protein, HSCRP, and if it is more than 2, colchicine is handy. We can give colchicine to reduce inflammation. But is there only medical therapy for inflammation? Not at all. Physical exercise is the most important anti-inflammatory agent. You have to do regular physical exercise, weight reduction, and control visceral adiposity. And there are certain other drugs also. See, GLP-1 receptor analogs. It reduces visceral adiposity, but again, it has got a strong anti-inflammatory action. And metformin has got anti-inflammatory action. Aspirin has got reduction of vascular inflammation. And again, as you have mentioned, gut bioflora. It is very, very important that you have to maintain the proper gut, the microbacteria level, so that it produces a lot of inflammatory phenomena all over the body. And there are a lot of research going on. People have been trying low-intensity cytostatic drugs, low-intensity methotrexate for the treatment. The research is going on. Stem cell therapy and vaccination against oxidized LDL. All these are on the pipeline. So definitely we have to take care of the inflammation, and that is a residual risk which is present even if you give high-intensity statin, all other medical agents to control LDL to the rock bottom. Thank you. Professor Ramakrishnan, anything you want to add? Otherwise, we'll go for questions.
So I think you really nicely summarized the thing. So I think as you rightly pointed out, more and more pathways are emerging and more drugs are being developed. So specifically target inflammation. So maybe you can answer some other questions, or like some other questions that have come in the chat box.
For patients with elevated hsCRP despite statins, what anti-inflammatory interventions are most practical and accessible? That's what I said. When it is well controlled, you check hsCRP, and if it is more than 2, colchicine 0.5 milligram daily is very good as far as the evidences which we have. However, you should always do lifestyle modification, dietary modification, proper physical activity, weight reduction, and control of other comorbid conditions, and diet which is rich in fruits and vegetables and nuts. All these things go a long way in controlling inflammation. It is not drugs alone. Physical activity is the most important anti-inflammatory agent.
I just want to add here. So a lot of in my practice, like unfortunately, India is a diverse country of two different population. On one extreme, we have a patient who had a young MI who stops taking statin. The other extreme, a bureaucrat or some well-educated guy who keeps on repeating hsCRP for primary prevention. And I would suggest that in this question that is being asked, we should not be repeating it for primary prevention purpose, because we don't have any evidence to any other molecules to be added in primary prevention. There is no point in repeatedly getting hsCRP done in a primary prevention setting, but they are very important in patients who have, whether you are, especially when you are primary prevention, when somebody is on statin. So the question is that already despite on statin. So there is no point in, because you are not going to start anything if even if the hsCRP is elevated. So there is no point in giving that fear mongering, and then you are at a high risk of MI and that kind of a thing in a young patient, 40-year-old, 50-year-old coming to your office. Don't do that. hsCRP is very important. If the patient has to be started on statin or not, there is a doubt, intermediate risk, then you get hsCRP done. But secondary prevention, what sir pointed out, Dr. Suresh Kumar sir pointed out, clearly for secondary prevention, you should get the hsCRP, they're elevated, you put them on, intensify the statin therapy. If the LDL is not under target, then you add the other agent like bempedoic acid, which also reduces hsCRP, and then you add colchicine if the LDL is under control.
Thank you. Even we consider the obese people. There is a metabolically healthy obese people, metabolically unhealthy obese people. The factor which differentiates a metabolically healthy person to metabolically unhealthy person is vascular inflammation or the inflammation. Inflammation, as again, Dr. Ramakrishnan, when he started his talk, is a low-grade inflammation, not the acute inflammation which we see. Is a very low-grade chronic inflammation which produces all the vascular damage and produces cardiovascular events. Then one more question. How do you manage residual inflammatory risk in high-risk Indian populations such as diabetics, CKD patients, and those with metabolic syndrome? Again, as I said, most important thing is regular physical activity. That is the most important anti-inflammatory agent. Very good physical activity, at least for 1 hour, maintain optimum body weight, reduce visceral adiposity, dietary restriction, take plenty of fruits, plenty of fluids, adequate sleep. Sleep deprivation produces inflammation. Adequate sleep, maintain gut bias. Actually, your health depends upon your gut health. That's what Hippocrates says. So, avoid excess fatty food, avoid late night dinner, lot of things. The food discipline is very, very important. And then take high intensity statins. Anything you'd like to add, Professor Ramakrishnan?
So I think absolutely, I think you nailed it. I think in a primary prevention setting, we should not be chasing behind colchicine and others. Beyond statin, there is no need to target anything in primary prevention setting. I think as you clearly said, what is actually causing this inflammation is what sir has pointed out. That is what we are targeting. Like that is what the primary cause of this low-grade inflammation. That is what we are targeting. Rather than the drugs, it is better to target the lifestyle changes, which are the ones which are causing the disease per se, which is primary cause of inflammation. I think we should focus on more aggressive risk factor reduction. I think there is a big study that came from Sweden that suggested that if 5 of your risk factors are under control, diabetics are actually having a lesser risk than normal population. So diabetics per se is not such a bad thing, provided if you are able to control the major risks of risk factors for diabetes, like risk factors inside diabetes.
Thank you. There's another question. Considering the high prevalence of infections in India, how should we interpret elevated hsCRP values and differentiate vascular inflammation from infection-related rise? It's a common question which most of the people ask in these kind of discussions. See, it is just like NT-proBNP. We get a lot of calls from medical ICUs and that this NT-proBNP is elevated, please come. You know, there's a lot of NT-proBNP is elevated in cardiac failure, but there's a lot of other conditions in which NT-proBNP is elevated. That is sepsis, renal failure, pulmonary embolism, respiratory infection, pulmonary hypertension, all these conditions, stroke. So most of the medical ICU patients are any of these factors plus NT-proBNP elevation. So just because a C-reactive protein alone is elevated, you cannot say there is a vascular inflammation. You have to do a clinical evaluation of the patient and rule out existing infection or inflammation any part of the body. Plus, you should always correlate with clinically rather than look only at the hsCRP value and treat the patients with colchicine or any other stronger anti-inflammatory agents. Again, Professor Ramakrishnan has explained that in this primary prevention trial, that is a Jupiter trial, those people with elevated hsCRP protein and low LDL has had more adverse effects than, so that about 10-15 years before itself, we came to know that inflammation plays a key role or a pivotal role in the development and progression and the development of adverse events in a person with atherosclerotic cardiovascular disease. Your take on that, Professor Ramakrishnan, about this CRP?
Yeah, so absolutely, you're right. As I pointed out in the lecture, also like most of the acute infections, the value is very high. So during the acute infection, the value could rise to say more than 10, 15, 20, 30. So those you are not supposed to interpret for your CV risk assessment. So then you are supposed to repeat the test and then find out the risk. So that is what is recommended. And then in such situations, better to wait till 6 weeks before you repeat. Or clinically there's a illness is going on, then don't get hsCRP done. It will be like any ESR, it's like CRP, ESR will be high. So as a physician, you know when ESR will be high. It is an acute phase reactant. It will be high in anything. So don't get it done if your purpose is for CV risk assessment. Don't get your hsCRP done during an infection or inflammation, clinically visible infection or inflammation.
Thank you. And then one more. How should we approach residual inflammatory risk in young Indians with premature coronary artery disease, where traditional risk factors don't fully explain the burden? All of us know traditional risk factors are diabetes, hypertension, hypercholesterolemia, family history of premature atherosclerosis, smoking. Again, there are a lot of small, minor risk factors, you say. Again, non-alcoholic steatohepatitis is considered as a cardiovascular disease equivalent. And then lack of physical exercise, visceral adiposities, and lack of adequate sleep, where the inflammatory where it produces vascular inflammation. And the food habits also should be regular. You have to take food at the proper time. Taking late food very late at night and taking highly fatty food and everything all produces a gut imbalance, which lead on to vascular inflammation. The gut bioflora is very, very important in maintaining the inflammation, producing the inflammation or reduction of inflammations. So again, the question is whether prebiotic or probiotic, all these medicines are helpful in reducing the inflammation. Again, Professor Ramakrishnan can explain.
So I think I agree with you, sir. I think what we have done in terms of already established ASCVD, in the ACS setting, we have started using colchicine when the patient is not having any risk factors and coming up with MI or ACS where traditionally there is no risk factor. But having said that, if you carefully analyze, most of the young patients are smokers actually. And even though we keep on saying that for one patient that you may see with no risk factor, there are very many who have actually multiplicity of risk factors. So even Indian population from interheart, 90% of the first MI can be explained by the 9 traditional risk factors of interheart. So that is where we stand. So that could be there, the 10% of patients whose MI cannot be explained by the traditional risk factors. You may consider start using colchicine along with an ACS in acute coronary settings. Like.
Thank you. Especially the young Indians, I say lack of physical exercise is glaring. People think that if you say, except people say in the office, I walk up and down, I walk a lot in the office, or I walk a lot in the... So that's not enough. You have to walk minimum 1 hour. All the people say minimum 10,000 steps if you are tech savvy. Ideally 15,000 or minimum 10,000 steps. So that is the minimum which is needed to produce any good biological effect. And for the weight reduction, there should be minimum more than 10% weight reduction from the baseline is necessary. You are a 90 kilo person. If you come down to 88, it is not enough. You are not protected. So these things are very, very important. And given the high burden of diabetes in India, should HSCRP testing be routinely incorporated in diabetic cardiovascular risk screening? We already explained. Again, I don't think it should be incorporated routinely. It should be used very, very judiciously. If you start using HSCRP protein or HSCRP in all patients, it all produces false diagnosis, over-treating patients and all this. What is your take on this?
I think our problem is that I think less than 15% of diabetes are actually on statin. That too adequate doses and reaching a therapeutic target in India. That is our problem. Like, I think let us first address that problem. Get all your diabetics first achieve their LDL goal and then achieve the non-HDL goal. Then you think of HSCRP or whatnot. But majority of the time, our problem is that we don't think about lipid in most of the diabetes. In primary care, many of the diabetes are actually not even prescribed a basic dose of statin. So we should address that particularly before we start in primary prevention. Because diabetes, anyway, you are going to put them on statin. Anyway, you are going to put their LDL to say 100 or 70, depending on the risk classification that they fall into. The moment you achieve, and then they are going to target, say, either 100 or 130 as the non-HDL goal. So the moment you achieve that, then somebody has any event on that, then you think of HSCRP. But I think before that, nothing. No need to look at to HSCRP in diabetes, who anyway needs a statin.
Definitely, in clinical practice, the primary target is LDL. You should bring the LDL as low as possible with any high-intensity statin, bempedoic acid, ezetimibe, inclisiran, or PCSK9 inhibitors. Bring it to the rock as low as possible. Then only you think about other like non-HDL cholesterol, ApoB, then lipoprotein little a, and all these things comes after that. Then inflammation like HSCRP. So the primary focus should be on LDL. That is why that's what all guidelines say. And with limited access to advanced inflammatory biomarkers in Tier 2 and Tier 3 cities, how can clinicians still satisfy residual inflammatory risk effectively? It is mainly clinical. This is all. See, you give high-intensity statin. Again, it reduces inflammation. That is one of the main mechanisms by which statin acts. So is enough, plus other things which I said, physical activity, weight reduction of visceral adiposities, other medicine. If you are diabetic, use GLP-1 receptor analog, which has got a better effect in reducing vascular inflammation and preventing progression of atherosclerosis. Metformin is effective. Give small dose aspirin, maintaining gut flora, stop smoking, and take a diet which is rich in Mediterranean diet, rich in fruits, nuts, vegetables, and everything. These all will go a long way in controlling inflammation. Don't think that you can treat inflammation only with drugs. These will work wonders. Then it's the only way to HSC reactive HSCRP, because interleukin 6 is again difficult to do in most of the centers. And your take on this and your comments on this, Professor Ramakrishnan?
Sir, absolutely. One simple thing to remember is whatever we know from our knowledge and from our experience and from our teachings, whatever we know that works in atherosclerosis, reduces events, 99% of them actually reduce inflammation. Drugs, the therapies, weight reduction, lifestyle modification, everything that we know to human being that reduces events, all of them definitely reduces inflammation. So that is a very important thing to understand. It is not just one colchicine or one high intensity statin that reduces.
See, the final word is inflammation is a reality. We must consider that there is a vascular inflammation, because that's what we saw most of the vascular atherosclerotic cardiovascular events in people with COVID. And we know the COVID produces a lot of thrombotic events. In one way is by producing vascular inflammation. And again, HSCRP elevation in most of the people with atherosclerotic disease. That's all my final word. Anything you want to add, Professor Ramakrishnan?
Absolutely, sir. You nailed it. Thank you, sir. Thank you.
Thank you. Dr. Sandesh?
Yeah.
Yeah.
So thank you so much, Dr. Ramakrishnan and Dr. Suresh Kumar for that very insightful discussion. I extend my heartfelt gratitude to Dr. Ramakrishnan for your very enriching and insightful points that you made regarding inflammation as one of the key drivers for atherosclerosis beyond LDLC, and targeting inflammation can further help to reduce the CV outcomes. So I also thank Dr. Suresh Kumar for steering the session so wonderfully, and thank you so much for your insights and your comments during the session. So I also thank the audience for making the session engaging, and also thank the sales and marketing team of Intas Pharmaceuticals, without whose efforts this event won't have been possible. So thanks again, all of you, and have a great evening. Thank you.
Yeah. Good night, everyone.
Thank you, sir. Thank you, sir. Thanks a lot, sir.